Welcome to the deep dive. We're jumping straight in today, and it's all thanks to one of you, a listener, send us some fantastic, really detailed revision notes.
That's right. And the topic is hypokalaemia, low potassium. It's absolutely crucial in healthcare. Pops up all the time.
So our mission today, take these notes, unpack them, pull out the really key bits, and make this potentially tricky topic, clear and easier for your revision or just general knowledge.
Exactly. These notes give us a great structure. Electrolyte imbalances can be a bit daunting, but focusing on one like potassium gives you a solid foundation.
Yeah, and we are working directly from this listener's notes on hypokalaemia. Think of it as us tackling this info stack together with you.
Absolutely. Potassium is fundamental.
Yeah.
So understanding what happens when it's low, that's key clinically. Let's start with the basics. What is it?
Okay, yeah, the definition. So hypokalemia, low blood potassium. The notes stress right away how vital potassium is: muscles, nerves, fluid balance, all sorts.
Precisely. And the notes give us the number. Usually a blood potassium level less than 3.5 mmol. But importantly, they also classify it by severity.
Ah, right. So it's not just low, there are degrees.
Exactly. The notes break it down. Mild is 3.1 to 3.5, moderate 2.5 to 3.0, and severe is anything below 2.5 millimol.
And that grading must influence how you approach it, right?
Really,
Yeah.
definitely. It dictates urgency. The notes also mention how common it is, especially in hospital settings.
Yeah, especially most cases are mild, severe is rarer, thankfully.
But here's a really key point the notes make, right up front.
Oh.
Even mild hypokalemia increases the risk of cardiac arrhythmias.
Wow, okay. So mild doesn't mean minor risk, especially for the heart.
Not at all. That's a critical takeaway. You see mildly low on a lab report, you still need to pay attention because of that heart rhythm risk.
That definitely changes how you look at those numbers.
It does. And the notes remind us where potassium actually lives in the body. We measure it in the blood, the extracellular fluid, but that's only about 2% of the total.
Only 2%. Where's the rest?
A whopping 98% is inside our cells. The notes mention the intracellular concentration is way higher, like 150 and 160 millimol.
That's a huge difference.
It is. And maintaining that difference, that gradient, is essential for how our cells work, especially nerves and muscles. The notes flag the Na plus K plus ADP's pump. That's the little machine in cell membranes, constantly pumping potassium in and sodium out to keep this balance.
So the blood level is just a tiny fraction, but the ratio between inside and outside is what really matters for function. How does the body keep this whole system in check?
Good question. The notes point straight to the kidneys. They're the main regulators, deciding how much potassium gets peed out.
Okay, so the kidneys are crucial.
And they're heavily influenced by the hormone aldosterone, which the notes mention comes from the adrenal glands. Aldosterone basically tells the kidneys to hold on to sodium and water, but get rid of potassium.
Right, aldosterone. Okay, so we've got the what definition, levels, the cardiac risk, even when mild, where it sits in the body, and the key regulators like the kidneys and aldosterone. Let's move on to the why. What actually causes low potassium?
Yeah, the etiology, the notes give a really helpful breakdown, categorizing the causes. Makes it easier to think through.
What are the main categories?
Increased loss is a big one, losing too much via the kidneys, the GI tract, or even the skin. Then there's transcellular shift, where potassium moves into cells. Also, simply not taking enough in decreased intake. And finally, some miscellaneous and congenital causes.
Okay, let's pull out some examples that the notes give. Kidney loss, you mentioned diuretics earlier.
Definitely. Thiazide and loop diuretics are highlighted specifically. Also, conditions where you have too much aldosterone, like Conn syndrome or Cushing's disease, and renal tubular acidosis, where the kidneys have trouble handling acids and electrolytes properly.
Got it. What about losing it from the gut, the GI tract?
The notes list the obvious ones, like diarrhea and vomiting. Interestingly, they point out that with vomiting, you can get a bicarbonate diuresis, which makes you lose more potassium in the urine too.
Ah, okay.
And things like bowel fistulae or laxative abuse are also mentioned.
Right, laxative abuse. And skin loss. I guess that's less common.
Less common day-to-day maybe, but significant with extensive burns or just really excessive sweating, according to the notes.
Okay. Now, this transcellular shift sounds interesting. Potassium isn't leaving the body, just hiding.
Sort of, yeah. It moves from the blood into the cells, so the blood test looks low, but the total amount in the body might be normal. The notes list causes like alkalosis when your blood pH is too high.
Okay.
Also, giving insulin and glucose, like when treating DKA, drives potassium into cells. And even things like adrenaline or beta-2 agonists. The notes use salbutamol, the asthma inhaler, as an example.
Wow, common treatments can do that. And decreased intake, that's just not eating enough potassium.
Pretty much. Malnutrition, anorexia nervosa are listed, or maybe someone's on IV fluids for a long time without enough potassium replacement added.
Makes sense. And the last categories, miscellaneous and congenital.
Miscellaneous includes things like chronic alcoholism or being on peritoneal dialysis. Congenital causes mentioned are Gittleman's and Barter's syndromes, specific genetic kidney issues affecting salt and potassium handling. Barter's, the notes add, often shows up in babies with growth problems.
That's a huge range of causes. The notes also list risk factors separately. Is that kind of summarizing?
Yeah, it frames it more around who's likely to get it. So again, prolonged or excessive diuretic use is a big risk factor. Excessive alcohol use too, underlying kidney or GI problems are listed, obviously linking back to the causes.
And certain meds too, like laxatives again, or corticosteroids.
Exactly. And why does this matter for you listening? Well, think about the patients you might encounter. Someone elderly on multiple meds, including diuretics. Someone with Crohn's disease and chronic diarrhea. Or a patient with an alcohol history. These notes help flag them as potentially higher risk.
Right. It helps with clinical suspicion.
The notes briefly mention pathophysiology too. It boils down to an imbalance. Intake versus loss, or that shift into cells, disrupting the normal concentration gradient.
Okay. We know what it is, why it happens, what does it look like, how common is it really, and what symptoms should you look out for?
The notes provide some epidemiology, citing UK and Swedish data. Prevalence varies a lot. Nearly 2% in older folks on potassium-losing diuretics, 2.5% in Swedes over 75.
But higher in some groups.
Yeah, much higher, over 20% in British adults on thiazides, and nearly 20% in outpatients with anorexia.
Right.
So depending on the context, you could see it quite often. And risk increases with conditions like heart failure or nephrotic syndrome.
Okay. And the symptoms, how would someone know they have low potassium?
Well, here's the thing the notes emphasize. Mild hypokalaemia is often asymptomatic. Someone might feel perfectly fine.
So you could have it and not know.
Absolutely. Symptoms usually start to appear or get worse as the level drops below 3.0 mmol. For moderate cases, the notes list things like fatigue, just general weakness, maybe constipation, pretty nonspecific stuff.
And if it gets severe, like below 2.5?
Then it can get serious.
Yeah.
The notes mention profound muscle weakness, which can even progress to paralysis. If it affects respiratory muscles, that's obviously critical. Significant GI issues can happen too.
The specific symptoms listed are muscle weakness or cramps, fatigue, constipation, palpitations, or irregular heart rhythm, and sometimes increased urination.
Those are the classics. And the notes add a couple of additional features to watch for. Muscle hypotonia, like sloppy muscles. And this is highlighted again, that increased risk of digoxin toxicity, especially if they're also on diuretics.
That digoxin link keeps coming up. It feels really important.
It's a major clinical interaction to be aware of. Low potassium basically sensitizes the heart to digoxin.
Okay, so we suspect it, history, risk factors, maybe some symptoms. How do we confirm it and dig into the cause? What tests do the notes recommend?
First up, blood tests. The notes say UNE's urea and electrolytes are essential to get that serum potassium level.
And they add a tip about sodium.
Yeah, if the sodium is also low, it might point towards thiazides or volume depletion as a cause. Useful clue.
What else in bloods?
Checking serum bicarbonate, glucose, chloride. And critically, the notes really stress checking serum magnesium. Low magnesium often occurs alongside low potassium, and you have to correct the magnesium for the potassium to properly replete.
Ah, okay, so don't forget the magnesium.
Definitely not. It's easily missed. The notes also mention a potential pitfall. Spurious hypokalaemia, where certain blood cells, like in leukemia, suck up potassium in the test tube after the blood draw, making the result falsely low.
Interesting. So bloods are key, especially UNEs and magnesium. What about an ECG?
The notes give clear guidance. ECG for all moderate or severe cases, so below 3.0 mmol. And even if it's mild, do an ECG if the patient is high risk, like someone with heart disease or, again, on digoxin. Connects back to that arrhythmia risk.
Right. And what are you looking for in that ECG?
The notes list the typical changes when potassium is below 3.0, flattened T waves, ST segment depression, and prominent U waves. Those are often considered quite characteristic.
Starlet T's, ST depression, U waves. Got it.
And in severe cases, the notes warn about potentially dangerous ventricular arrhythmias.
Okay. How about urine tests? How do they help pin down the cause?
They're really useful for figuring out if the kidneys are wasting potassium or conserving it. The notes say to measure urinary potassium.
How do you interpret that?
Well, if the urine potassium is low despite low blood potassium, it suggests the kidneys are doing their job trying to hold on to it. So the cause is likely poor intake, a shift into cells, or maybe GI losses.
Hmm.
But if the urine potassium is high, even though the blood level is low, that points the finger at the kidneys. They're inappropriately losing potassium. That helps narrow down the causes significantly.
That makes sense. The notes also mention checking urinary sodium.
Yes, and they highlight a specific pattern. Low urine sodium plus high urine potassium might suggest secondary hyperaldosteronism, often seen with volume depletion. The body's trying to save salt, but losing potassium as a consequence. Ternary osmolality might also be needed for proper interpretation, the notes add.
And there's a list of other tests, too.
Yeah, those are more for digging deeper if the cause isn't obvious. Things like plasma renin and aldosterone levels, cortisol, maybe adrenal imaging tests aimed at finding specific underlying conditions like Conn syndrome or rare kidney problems.
All right, so we found the low potassium. We have an idea why. What do we actually do about it? What's the management plan according to the notes?
The core goal, the note state, is twofold. Get the potassium level back to normal and fix the underlying reason it dropped in the first place.
Right, you can't just patch the leak without fixing the pipe.
Exactly. Otherwise, it'll just happen again. The general strategies listed are oral or IV potassium supplements, dietary changes, adjusting medications if they're contributing, and managing related issues, like correcting that low magnesium we talked about.
The notes mention an optimal range.
Yeah, they mentioned some studies suggest aiming for 4 to 5 mmol might be ideal, particularly in certain patient groups, though just getting it back into the normal range is the primary goal.
And like with diagnosis, the urgency depends on the level.
Absolutely critical. The notes give a clear, tiered approach based on those severity levels we discussed. 8, 2.5 millimol, severe. Urgent discussion, likely hospital admission.
Okay.
2.5 to 3.0, moderate. Urgent assessment, seek advice. 3.1 to 3.5, mild.
Yeah.
Monitor, replace if necessary, often done as an outpatient. Severity really dictates the next steps.
So how do you actually give the potassium?
For milder cases or ongoing replacement, the notes focus on oral treatment outside the hospital. Treat the cause, give dietary advice. They list good sources like bananas, tomatoes, avocados, potatoes.
Classic.
Yeah. And then potassium supplements, usually KCl, often as liquid or effervescent tablets, taken in divided doses. And, crucially, monitoring the levels to make sure they're coming up.
What about the more severe cases needing hospital care?
In hospital, especially for severe hypokalaemia, IV potassium is often needed for faster correction. The notes give an important practical point. Give IV KCl via a peripheral line, usually, but with monitoring.
Needs monitoring, okay.
Yes, and it needs to be diluted properly and given at a controlled rate because high concentrations can damage veins and be dangerous for the heart. For real emergencies or large replacements, the notes mention considering a central line.
Got it. And there was a specific mention about eating disorders.
Yes, if the hypokalemia is related to anorexia or bulimia, the note specifically includes psychiatric referral as part of managing the underlying cause.
Okay, treatment plan clear. What about the long term? Prognosis. And what happens if things go wrong or it's not treated?
Prognosis, according to the notes, really depends on the cause, how severe it was, and how quickly it was treated. Generally, if it's managed properly, the outlook is good.
But if the cause isn't fixed?
Then it can recur, and complications can develop.
Before we get to complications, let's quickly cover prevention. Diuretics came up a lot as a cause. How did the notes suggest preventing it?
Good point. The notes say for low-dose diuretics, you might not need routine prevention. But for higher doses, or if someone does become hypokalemic, you should think about it.
And how? Just give potassium pills.
Interestingly, the notes suggest the preferred strategy is often to switch to or add a potassium-sparing diuretic like spironolactone or amiloride, rather than just adding KCl supplements to the potassium-losing one.
Okay. Use a drug that holds on to potassium instead.
Exactly, but then there's a big caution.
Don't mix them.
Right. The notes explicitly warn against combining potassium-sparing diuretics with potassium supplements because that puts you at high risk of the opposite problem. Hyperkalemia, too much potassium.
Okay, that's a key safety point.
Definitely. If supplements are used for prevention, the notes mention doses like 25, 50 millimol per day. But stress caution, especially in the elderly or those with kidney problems, as they might not clear potassium well. And long-term use needs regular blood test monitoring.
Got it. Prevention strategies are important. Now back to the potential problems if hypokalemia isn't treated properly, the complications.
The notes list several serious ones. Top of the list, cardiac arrhythmias. especially as we keep saying in vulnerable people or those on digoxin. That digoxin toxicity link comes up again as a major potential complication.
What else?
Worsening muscle weakness,
Hmm.
potentially progressing to rhabdomyolysis, that's serious muscle breakdown. Kidney function can also be affected, leading to nephrogenic diabetes insipidus, where you can't concentrate urine, or metabolic alkalosis.
And you mentioned the risk of treatment itself.
Yes, iatrogenic hyperkalemia, accidentally overshooting and causing high potassium during treatment. It's a balancing act. The notes also mention a link to hepatic encephalopathy in patients with cirrhosis.
So quite a list of potential dangers.
Absolutely. It really underscores the final point made in these notes. Prompt diagnosis and proper management are vital to prevent or lessen these complications. Understanding all these details, from causes to ECG changes to treatment nuances, it really matters for patient safety.
This has been incredibly helpful, really walking through hypokalemia using these listener notes as our guide. We've covered the definition, the causes, from common drugs to rare syndromes, how it shows up, how you investigate it with bloods, ECGs, urine tests, and then the management, thinking about severity, replacement, prevention, and finally the risks if it's missed.
It really has. And the big takeaway for me, reinforced by these notes, is that even mild hypokalemia isn't necessarily benign, especially because of that cardiac risk. It highlights how interconnected everything is: kidneys, hormones, muscles, heart, all tied together by electrolytes like potassium. Knowing these details helps you spot potential problems earlier.
Couldn't agree more. A massive thank you again to the listener who sent in these notes. They provided a fantastic framework for this deep dive. And if you, listening, are tackling exams like the MSRA or just want solid resources on topics like this, there are tools out there.
Yeah, keep digging into these core concepts. Understanding electrolytes is so fundamental.
You can check out pastthemsra.com and also freemsra.com for resources. Thanks so much for joining us on this deep dive.